Good morning, senior colleagues. Good morning, colleagues and small trade family. I'm going to discuss Aviola Cleft and Aviola bone grafts under the following outline: introduction, embryology, historical perspective, classification, indication for Aviola bone graft, management, challenges, and the way forward. I'm not going to talk too much about most of these aspects, like the embryology and anatomy, because most of the other lectures have covered most of these aspects. So we go straight on to cleft. A cleft is a gap, whether in the soft tissue or in the bone, or both of them combined together. Cleft lip and cleft palate are the most common than in the rest of the face. It can be a split in the bones or the soft tissue, just as we see in this young child with bilateral cleft lip and palate and alveolar bone graft, alveolar cleft. Alveolar cleft is just a break in the continuity of the alveolar process. It is usually congenital and typically occurs with either cleft lip or cleft palate or more of cleft lip and palate, two of them combined together with alveolar bone cleft. Alveolus is derived from a Latin word meaning small cavity. The dental alveolus is the tooth cavity or socket, and this is where the teeth are attached with their own periodontal tissue that makes them to be strong within the alveolar socket. Facial development starts from the 4th to 10th week of gestation with the diffusion of the unpaired frontonasal process, nose and future, paired maxillary swelling, which form the cheeks and upper lip, paired mandibular swelling, which form the lower face, lower lip, and the chin. See all the processes, how they come together to form the face. But any interruption along the way of their line of fusion, whether in the midline or by the side, can lead to the cleft of the lip, palate, or the alveolar bone. The primary alveolus is anterior to the incisive canal, as can be shown here. The same thing with the alveolar cleft. Permanent teeth above the alveolar cleft are not sustainable because there is no adequate bone stock or alveolar bone into which the tooth can erupt. It normally affects the maxillary cuspid or canine tooth, and this is the one that normally erupted into the alveolar cleft space. Sometimes it can also affect the lateral incisor, which the two of them erupt between the age of 7 to 12 years. Occasionally, as I said before, it can be between the central and the lateral incisor. Just as we see in this young child, she had a cleft lip, which was repaired when she was 3 months old. Then the cleft palate also repaired at the age of 12 months. And then the alveolar cleft, as shown on the left-hand side, as the arrow is showing in this alveolar area. Classification, it can be classified as complete or incomplete. The historical perspective: first bone grafting to the alveolar cleft was carried out in 1901 by von Esselbach, which used pedicle osteocutaneous plaque to reconstruct the palatal defect. But the first successful bone graft to alveolar defect was by Dracha in 1914. He utilized a tibial bone graft, including periosteum. View reports was unsuccessful in 1931 when he uses tibial chips. Sorry, the slide is not coming on. Sorry, the slide is back. Miller wrote that there was a relative lack of enthusiasm for alveolar grafting until the 1950s. During the 1950s and 1960s, many surgeons began employing primary bone grafting of the alveolus during the early months of life. Sorry, we're having a little bit problem with the network. The slide is hanging from time to time, so be patient with me. So Johansen and Eck Olison in 1961 advocated 3 stages of primary bone grafting. The question is that what are they trying to accomplish by carrying out primary alveolar bone grafts? Early article by Bra, Cronin, and Reeves in 1962 provide a valuable insight. In the case of unilateral cleft, they believe access of bone and soft tissue on the cleft side, pull of the repair lip on the non-cleft side, causes flattening and retrusion of the central face. They also believe that early repair of this unilateral alveolar cleft provided a bridge between the retruded cleft side and the maxillary growth center of the cartilaginous septum that was attached to the non-cleft side, allowing normal growth. This same thought process was echoed by Spook in 1965 when he stated that the alveolar cleft will require special measures to prevent or correct collapse of the maxilla. He included bone grafting as one of these special measures. Primary bone grafting continued throughout the 1970s in many parts of the developed world. As described by Miller in Cleft Graft, Kenneth L. Pickrell followed 25 patients that received primary alveolar bone grafting. Sorry, the slide is hanging again. It will soon come back. Sorry, it is still hanging.
Dr. Akintububo, if you hover over the WACS logo at the bottom left.
Sorry?
If you move to where the WACS is, below it, there are some arrows that you can use to move the slides.
Okay, thank you. So, findings by Pickrell were primary rib grafts in the maxilla do not increase in size concomitant with facial growth and development. Teeth do not migrate and erupt spontaneously through a rib bone graft. Rib bone graft do not form a true alveolar process. A permanent alveolar notch will still remain even after all these early bone grafts. The orthopedic effect of the bone graft decreases as its incorporation increases. Riemann of Germany in 1969 of grafting, and he was able to compare primary alveolar bone grafting and secondary alveolar bone grafting, which now leads to developing a situation in which they all agree that they should be delayed alveolar bone grafting rather than having primary alveolar bone graft. He also found out that permanent stabilization of the maxillary segment did not result from early bone grafting of the alveolar process. Bone grafting, which give an intrinsic positive value. The benefits of secondary bone grafting are bony support for tooth eruption and stabilization of the maxilla. What are the problems with alveolar cleft if it's not treated? We have flat and asymmetric support of the lip, residual oronasal fistulas, periodontal disease due to chronic inflammation from the oral oronasal reflux through the fistulas, and there may be possibility of a loss of some teeth which might later in life require bridge work, dentures, or some other procedures that we might needed to use to replace those missing teeth. So indication for secondary bone graft. Help to restore the dentage, support the nasal base, stabilize the maxilla, and restore volume to the lip. Secondary alveolar bone graft timing is normally being carried out during the period of a mixed dentition, especially between the ages of 7 to 12 years. But this is the time when the lateral incisor and the canine normally erupt. Eruption of the lateral incisor and canine are carried out at this time. A bone graft prior to eruption of the lateral incisor or the canine might not be successful. The time when the two of the teeth are about to erupt, then we might have a good success, which help in the stabilization of the maxilla. And by this age, between 7 to 12 years, transverse maxillary growth is complete. Thus, no inhibition of maxillary growth in this dimension. For us to be able to have a successful secondary alveolar bone graft, a team approach is required, and a good knowledge of alveolar bone graft is also necessary. This will involve pediatric dentists, orthodontists in particular, oral and maxillofacial surgeon, and speech pathologists. Secondary bone grafting involves appropriate flap design with wide exposure, nasal floor reconstruction and closure of oronasal fistula, packing bone defects with cancellous bone, and coverage of bone grafts with gingival mucoperiosteal flaps. Once you are able to do this and you understand the principle involved, then you will be able to carry out a successful alveolar bone graft. There are two types of bone that we have that can be used. We have membranous bone and endochondral bone. But it has been found out by the research carried out both on rabbit and monkey that membranous bone is far better than endochondral bone because the volume of bone left in that cleft after grafting will be more with membranous bone than that of endochondral bone. What are the source of materials for alveolar bone graft? We have the autogenous one, which involves iliac crest, cranium, tibia, rib, or mandibular symphysis. We also have a non-autogenous bone materials. A combination of the two of them can also be carried out, regardless of the timing and the materials used. The main principle in approaching alveolar clefts have been well described in the literatures. The iliac crest is one of the most popular alveolar bone graft sources, but it also has its own drawback. The cancellous portion is the most commonly used part of this bone, although the cortical portion is sometimes used in conjunction as a buttress or stent to receive soft tissue contractile forces, as we are going to see in some of the patients that we have operated that will be shown later during the course of this lecture. The drawback with iliac bone graft is donor site scarring, post-operative pain resulting in delay, ambulation, and potential for cutaneous nerve injury. It is being carried out in the hand of inexperienced surgeon. Tibial bone is another source of carrying out alveolar bone grafting. This requires threatening with no direct opening of the site. The technique result is there is less pain post-operatively and there is a shorter hospital stay. Rib graft, it has a limited use because of donor site mobility, visible scarring, pain. Rib grafts have also been criticized for difficulties in orthodontic tooth movement. Autogenous bone grafting is bone grafting because of the patient height, which results defibrinated bovine bone or beta tricalcium phosphate. All this reduces the amount of autogenous bone that you need to harvest from the iliac crest if you combine the two of them. So using the autogenous and autologous source of bone materials combined together will reduce the amount of autogenous bone that's going to be harvested for bone grafting. The competent human bone morphogenic protein is another area that researchers are looking into now in order to see whether the morbidity associated with taking bone from other parts of the body will be reduced. It is being in use. It causes inductive conversion of mesenchymal stem cell to osteoblasts, known as in situ osteogenesis. This novel method for primary alveolar bone graft bone reconstruction avoids donor site mobility and does not require close approximation of alveolar segment as stated by gingival periosteoplasty. I've never used one before because it is not available in this part of my country. But it is an area that all of us need to look into for use in our own area of specialization. No consensus on the correct method to reconstruct the alveolus, depending on what you are using in your own area of practice. Primary bone grafting failure due to overly aggressive technique and wedging rib graft into the clefts, transplanting resected segment of the bone into the alveolar cleft, wide dissection along the alveolus bone and the hard palate for tibial graft placement was the result of why we are having failure when primary alveolar bone graft was being carried out before. This was due to some of the researchers who said they still prefer to use the primary alveolar bone grafting as compared to secondary alveolar bone grafting. Sorry, I'm having a little bit problem. Another research that was carried out by Van Asse et al. In 2005 also said part of primary bone grafting can now reduce the problem of having mid-phase hypoplasia. But I've not tried that technique because most surgeons today prefer to carry out secondary bone grafting and primary bone grafting early stage. There are different techniques that are involved at all concept to adequately reconstruct the alveolar clefts with the bone graft according to this technique. That is, you must make sure that the 5 different sides of the cleft is adequately packed with bone, exposed and closed tightly with periosteal tissue in order for you to have a successful secondary bone graft. The anatomies of units of the alveolar clefts are the nasal floor, the medial cleft margin, lateral cleft margin, anterior alveolus, and posterior alveolus, which is the palate. Just as seen in this diagram, you can see the whole alveolar cleft here. Then looking at the different walls, we have the nasal floor on top, the medial wall, the anterior wall, the posterior wall, and Hello, are you still there? Can you hear me?
We can hear you. Proceed, please.
Can you hear me, please?
Proceed. Continue.
Hello?
Continue.
Okay,
We can hear you.
Thank you, sir. So, in our unit, we only have a maxillofacial surgeon, the anesthetist, the pediatric surgeon, the pediatrician, plastic surgeon, and we don't have an orthodontist. So when the child came to the hospital, it is being assessed by all of us, and the diagnosis is made, whether it's cleft lip, palate, or cleft lip with Aviola cleft, or with that of palate. So once the assessment has been made, all the diagnosis is written in the case note, and the timing of the surgery is being passed on to the family. So at each particular point, the patient knows when to come back for their surgery. So during the surgery, the patient will be investigated we normally carried out full blood count and MP, which is malaria parasite. Those two things are very paramount for all the children. Once there is no any other medical problem, we don't carry out other investigation. Proper examination of the patient is carried out both by the surgeon and the anesthetist. If possible, the pediatrician will see, and the patient is prepared for the surgery. On the day of the surgery, we normally infiltrate the mucosa, both the palatal and the labial mucosa with 2% inocaine about 10 minutes before the surgery will start. We use this type of flap for our own technique, where all subgingival incision at which the soft is complete area is infected and it bleeds a lot. So all this tissue must be incised, especially in some patients where there is palatal fistula also. The palatal tissue is also raised, the fistula is also exposed, and the dead tissue around the fistula area is removed, and then the palate is sutured in a corrected way for the bone graft is being done. When this flap is being raised, we normally make sure that there are two teeth. The buccal extension would be after two teeth on both sides of the cleft. Now, exposure of the cleft area. One thing that we carry out, and this is the nasal floor, and we make sure that all the neck be reconstructed, but involve leaving the Hello, can you hear me?
We can hear you. You can share your screen again.
Okay, thank you. So some other people use this technique, as we are seeing in this picture, leaving about 4 to 5 millimeters of attached gingiva around the teeth. But why we don't use this technique is because of compromise to the blood supply to that tissue. Gingivoperosal flaps are elevated to close the palatal defect. Nasal floor is closed with mucoperosal flap elevated off the piriform aperture. These flaps are sutured for closure of the alveolar cleft. If the soft tissue closure is stable, then the bone graft can proceed. But if the soft tissue closure is not enough in order to close the cleft alveolar bone completely, then we might have to leave the soft tissue for now and no bone graft will be done until we have enough tissue to close over the bone graft. This is the other technique that is being used in some centers that I described before, but I don't use this technique because of the possibility of this attached gingiva, which might be due to compromise of blood loss. So I use subgingival incision. So here also is showing the cortical bone being put in the floor, in the nasal floor, in order to prevent soft tissue growing into the floor of the nose after packing the cleft with cancellous bone. Soft tissue integrity is, if it's not adequate, then the soft tissue is completely closed, as I said before, and bone grafting is delayed for 3 to 4 months. Placement of the cortical bone on the side of the cleft, especially on the anterior side, is very important. Cancellous bone is also placed on the interior part of the defect, covering all the 5 walls that we'll talk about before. What are the pitfalls of carrying out alveolar bone graft? From the cleft surgeon standpoint, it is important to work closely with an orthodontist familiar with the needs of cleft patients. Why is this so? Because in some cases, some patients have been operated in another center, and when they come to see us for alveolar bone graft, we find out that the anterior region of the palate is collapsed. And if you carry out bone graft in that kind of situation, the patient might still need secondary expansion of the alveolar bone. So what we normally do, if we have a patient with collapsed alveolar anterior palate, which can be constructed by technologies from other centers, and then the patient will use it for some period of time in order to expand the anterior part of the palate before the bone graft is being carried out. But it can also be done post-operatively, but that will be more complex than when it was done earlier before the bone grafting. So you need an assistance of an orthodontist for you to be able to carry out a successful alveolar bone graft. A clearly defined treatment plan prior to and following bone grafting is very essential. Following placement of the bone graft won't help and should be placed after the incision appears. Sometimes a moderate amount of scar tissue in and around the cleft deformity and blood flow to the gingival flaps may be somewhat compromised, but all these are minor complications. But the orthodontist will help us in order to have if the Aviola may be necessary later, and this should be discussed in the treatment plan. Yes, sir. Hello.
Can you share your screen because we are not seeing the video again? Can we see your slides?
I'm trying to go back to it, sir. Can you see the slide now?
Not yet. Just try again. Okay, it is on the way.
Can you see me, please?
We are not seeing your slides.
Okay, just a minute. Let me go on again. Can you see me now?
Yeah, we can see you now. Okay. Good. Click on the slides. Okay.
Can you see me now?
Yeah, we can see you. Go
Can you
ahead.
see it now?
Please. Yeah, we
Okay.
can. Go ahead.
So I can carry on.
Yes, please.
So as I was saying, if the alveolar cleft deformity is quite large, a secondary bone grafting procedure will be necessary later, and this should be discussed in the treatment plan. In case of bilateral cleft deformities, it may be necessary to obtain cancellous bone from both hips. Depending on the size of the cleft on both sides, what I used to do if I have a bigger cleft alveolar bone in a bilateral cleft is to do one side first, especially if I find out that the blood supply to the prolabium is going to be compromised. So I will do one side of the cleft early, then 6 months later, the other side of the bilateral cleft can also be done. But if the alveolar cleft is not wide on both sides, and we believe that the soft tissue around the prolabium is good enough to maintain the blood supply, and we could have enough bone, cancellous bone from one hip, because I try not to use the both legs. But there's nothing wrong in using them, but I try to use one. So if the bone is going to be enough to cover the two bilateral clefts, I do them at once. Or if not so, then you have to be deferred. Do one side at a time. Appropriate post-operative dental X-ray at 6 months to 12 months will give the best information for evaluating the take of the bone graft. This is the marking for the iliac bone graft from the anterior tubercle towards, and this is one of the patients that we operated. I used to take my own bone graft from the medial aspect of the iliac bone now. The reason being that there's no need for stripping most of the muscle from the lateral side. But when you strip more muscle from the lateral side of the iliac bone, then it delays the number of days that the patient is going to stay in the hospital. Then for them to start walking, they might have the affected gait for about 3 to 4 weeks. But when you take it from the medial aspect of the iliac bone, then within 2 to 3, you'll be able to discharge within 5 to 7 days. So a cortical bone window is open on the medial side, and the cancellous bone is chiseled out or scooped out as much as we needed. And when we finish, small part of the cortical bone on the medial side is also cut out. The floor of the nose. So bone will not be able to grow.
Hello? 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 Akintububo?
Hello, sir. Can you hear me now?
I can hear you. Your
Can I
screen has been
continue,
locked.
please?
Yes, let's have your screen and then you can continue. We just have a few more minutes.
Okay.
Okay, let's have your screen and then you can continue. Okay.
Thank you. Do you have it now?
Yeah, yeah, we have it. Go ahead. We can't hear you.
Sorry, sir. Just a minute. Okay. I was here before. So this is another girl with a cleft lip palate and Aviola cleft. Lip prepared at the age of 3 months, palate 14 months. And this is a post-operative X-ray after 3 months. And this was the girl 2 weeks after the surgery. And this is another patient with a complete lip and Aviola cleft, no palate, came at a little bit old age, 9 years of age. The cleft lip was done. Then she came back for bone grafting. This is the Aviola cleft, and it has already been packed with bone here. This is the bone that we harvested from the iliac crest area for the repair of the bone graft, for the bone cleft. And this was the patient immediately post-operative. And this is her 1 week after the surgery. This another girl also came at the age of 3 months. And she stayed with us for about 6 months for her to prepare her for her cleft. She was pregnant again 4 months after she was born. But she came back at the age of 9 years for Aviola bone graft. This is the graft. This is the cleft area here. This is the medial wall. This is the lateral wall. This is the floor. This is the anterior surface, and on the palate, the posterior wall. So all the parts of the cleft has been packed with Aviola bone, ancillous bone. The success rate of Aviola bone graft is between 90 to 95%. Fortunately for us, we have not had any broken down patient because we have been able to operate about 18 patients for smile train in the past 10 years. So majority of the patients are now coming back for their Aviola bone graft in the next 1 or 2 years. Post-surgical orthodontic care usually involves maxillary arch support and guidance of the erupting canine into position. Result of inadequate soft tissue coverage of bone graft will lead to the exposure of the bone that will raise from the iliac area, and this might lead to breakdown of the soft tissue size. Our patient give a pre-operative control during the surgery. Immediately after the surgery, we normally use a bupivacaine 0.5% double diluted to 0 in order to control the pain, and then we put it on analgesics, amoxicillin, and flagyl. Patients start eating immediately after 2, 3 to 4 hours after our surgery, but we always encourage thorough mouth toileting with warm water and salt mouthwash, especially immediately after, before and after eating. And we make sure that the patient does not have any milk as milk, because we find out that milk can be clogged at around the area where you put your sutures, which can lead to a lot of infection. Most of them live on liquidized diet and soft diet for the first few days before they can now start with raw food. Autologous bone diffusion. Autologous bone, not perfect source for Aviola cleft reconstruction. Many ongoing efforts to find an alternative source for graft materials is on. Bone morphogenic protein delivered on a collagen sponge is another successful way of repairing alveolar bone clefts. But the problem is that it's quite expensive and its availability is limited, because I've not seen one before, but I believe in developed countries it is being used, maybe in our own continent. The next few years, we should be looking at this area. Conclusion: alveolar bone graft should not be an afterthought in the care of cleft lip and palate patients. It has functional and aesthetic significance. The construction potentially carries a significant benefit to the patient. Timing of repair is an important consideration. The choice of graft source must take into account donor site, mobility, as well as the intrinsic characteristic of bone selected. Thank you.
Thank you so much, Dr. Akintububo, for this wonderful lecture. I guess we had some hitches here and there, but I must congratulate you for behaving as a true surgeon. Are you with me?
Sir.
Yeah. So for those who are not here at the beginning, this lecture is on alveolar bone graft, and it was given by Dr. Benedict Akintububo from Federal Teaching Hospital, Gombe. Now we have some questions for you, Dr. Akintububo. The first question is this: what is the significant difference between a primary and secondary alveolar bone grafts? Are you with me? Hello?
I can't hear you, sir. Hello?
I'm around now, please.
Hello, sir. Can you hear me now?
Yes, I can hear you now.
Sorry, I can't hear the question before.
Okay.
Hello?
Can you hear me now?
I can hear you now, sir.
Okay. Thank you once more for the presentation.
Thank
The
you, sir.
first question is this: what is the significant difference between a primary and secondary alveolar bone graft? Are you with me?
Yes.
Number two, how do you measure success rate of alveolar bone graft?
Okay.
I think you can start with this while I compile the others.
Okay. Well, the primary bone grafting, there have been a lot of discussion, a lot of research. That is where it was started from. But they find out, possibly due to a lot of radical dissection in those days, the success rate was very bad. But some also suggested that with minimal dissection, not as much as what they were doing before that, they have some success. But at the end of it all, from 1950s and 60s onward, it has been found out that the secondary alveolar bone grafting far better than the primary alveolar. leads to maxillary hypoplasia in most of those patients that had the treatment. And they also find out that the cleft is not even completely formed. There's always a little bit gap between the two sections of the alveolar bone. So that is why most people favor the secondary bone grafting. That by the time the patient is 8 to 12 years of age, the growth of the primary palate will have been completed. So the issue of having hypoplasia of that area will not come into being. And even if you have to do palatal expansion at that age, it will be much easier for you to do. That is why most people today favor secondary bone grafting. So majority of centers are no more doing primary alveolar bone graft. Some might still be doing it, but with all the research and the studies shows that they are not having a good success with primary bone grafting. Then measure second success rate of alveolar bone graft. I said that for you to measure it, you must take X-ray. Some of the X-ray, depending on the facilities you have on ground, because most center does not have an orthopantomogram machine. If you don't have that, you can still take peripheral X-ray, you can take a occlusal X-ray. So before the surgery, you take your X-ray, and 3 months, 6 months, and 1 year after the surgery, you still take your X-ray. And then with the eruption of the canine or the lateral incisor coming into that area of your grafting, also is part of measuring your success. So you must follow through, not just operate the patient and let them go. You must follow through with successive X-ray.
Okay. As a follow-up to the first question, is there a place for tertiary alveolar bone graft in cleft patients?
Tertiary.
Mm-hmm.
Sorry. Do you say tertiary, sir?
Yes.
Yes, it's possible. Because if you had the first bone graft, if it failed, you can go ahead and redo it again. You don't give up until you are able to get some good results. I said in the course of the lecture that even in some cases, if you are not able to get enough bone, another surgery later on. But there are some patients, you open their iliac bone area, even on both sides, you might not be able to get enough cancellous bone to cover the alveolar cleft. But I said that it must be part of the planning before the surgery that the patient's relatives should be informed in case you don't have enough bone to cover. Do I answer your question, sir?
Okay, exactly. It's not mine. It's from the chat room, from the audience.
Okay.
Now, and another question, please. When placing the wedge-shaped grafts, do you fashion the edges to make it a tight fit, or do you fill up with the bone chips?
I only use cortical bone for the nasal floor.
Okay.
All the other area I use cancellous bone. I don't use cortical bone. The only thing that we suggested towards the end of last year is possibly to scratch or burnish the surface, the medial and the lateral surface of the alveolar bone. Possibly that might make it to take to be able to take well or so, but we have not started doing that. But with all the 18 patients that we did, the result has been very good. None of them has failed.
Okay.
Mostly you use cancellous bone, not cortical bone.
Oh, okay. Thank you so much. How do you prepare the site for alveolar bone graft?
Prepare site for alveolar bone graft.
Yes.
Well, as I said in the course of the discussion, patients must be properly examined right from the first time you are seeing them in the clinic. Involve all the other colleagues who are in the team. Diagnosis must be made, family informed what type of surgery needs to be carried out, and at what stages of life of that patient all the surgery needs to be carried out. Even the most important thing is that most of the parents might have forgotten, but you need to have their phone number, you need to have their address. Then our social health workers who work with us try to get in touch with them. Because in the past 7 months, the age of 8, 9, 10, those that were operated 8, 9 years ago. So we are now having most of them coming back, but we still need to reach them. So when the patient comes in, we re-examine the whole place. Some might be having infection. If they're having infection in the gingival area, the alveolar cleft area, then you place them on antibiotics. You don't just do the surgery directly. Or if they are not having infection, then you go ahead and prepare your patient, do your routine investigation, take your X-ray, and then inform the parents what you are going to do. Your anesthetic is available, assess the patient to guide, the patient is fit for the surgery, and you go ahead. Then during the surgery, I mentioned the type of flap we use. You can prepare this alveolar bone graft from the X-ray itself. But the X-ray will show you whether it's a wide cleft or it's a small cleft. So it will tailor, it will help you to be able to know how much amount of cancellous bone you are going to need. Because if it's a big cleft, then you have to inform the parents. Possibly you might use the two iliac crest area, or possibly you might do a bone graft now and then come back again and do another bone graft if you cannot fill the whole cavity. So these are the areas you must inform the parents all about. And once you raise your flap, you'll be able to see the size of the cleft. And from there on, you'll be able to know whether you are closing primarily the soft tissue. If the soft tissue is not enough to close the graft area, or if the soft tissue is enough to close the graft area. But you don't take the bone graft until you have exposed the cleft area and you have repaired the floor of the nose and all the necessary soft tissue repair you have to do. It's only when you have done that and you see that there is enough tissue to close the graft area that you now go and take your bone graft. And once you harvest your bone graft, then you'll be able to put it back in the cleft. So these are the procedure that we follow for the alveolar bone graft.
Thank you so much. Now, how can we convince patients with clefts from the rural areas that they need alveolar bone grafts?
Well, this is very easy, because in my own management of patients, I believe in talking to the patient more than carrying out the surgery. Because as you carry the patient along, most of our people, to be sincere with them, they are quite very good. Once you give them enough information, sometimes you have some leaflets that you give to them, and then you get in touch with them from time to time. Not only after you finish the cleft lip, they are abandoned. No, because we are also carrying out some research. And you find out when you recall this patient, majority of them are happy to come back. So once you inform them from day one, this is the type of problem this patient is having: cleft lip, cleft palate, cleft alveolar bone. And these are the different timing for the surgery. They will come. Even though some of them that are not coming will have their record, we keep in touch with them to bring them back. So it is very easy for most of our patients to come back. Even some of them will even come and see you when you didn't even ask them to come for review. But they are happy with the way that their baby is looking like now. Because the issue of repairing cleft, with some of the lectures I have listened to recently, we are now moving away from just joining the lip together. Aesthetically, the patient must be happy from day one of repairing their lip. And that is why it is important to do open rhinoplasty with primary cleft lip at the same time. Because when the parents are happy, then they are likely to come back to you. But if they are not happy with the first surgery, they are not likely to come back. So these are some of these. Even though if your initial result is not too good, but letting them know that something can still be done, this patient will come back. So these are the areas we work upon to make sure we get our patient back. And they will be able to know that having the alveolar bone graft is the best benefit for them. Because when the teeth are coming out, they are not going to look nice. Imagine having a girl with crooked teeth. The family will not be happy. So once we inform them, they will come back. And we thank Smile nowadays, they started treating patients in Kano for orthodontics, which is part of the free treatment. So we're likely to be sending some of our patients to Kano for their orthodontic treatment until we have our own orthodontists. So these are the way we're able to get the patient back to be able to be sure that they have their alveolar bone graft.
Okay, thank you so much. We are quite running behind time, and I will just mention a few more questions. Please, what are the pros and cons of each of primary and secondary alveolar bone grafts? I guess you have mentioned this a bit, but can you just highlight it briefly? Pros and cons.
Okay. The the pros of primary alveolar bone graft for those who used to do it those days, they believe that bridging the gap between the two segments of the alveolar bone will prevent a lot of infection, will allow the teeth to be able to erupt to that area, and allow to prevent oronasal fistula, which is one of the problems with most of the patients. But the problem with the primary bone grafting is that they found out that the bone they were using those days, possibly because they were using the rib, that the teeth are not actually erupting into that area in a good way, and then they are not having complete closure of the cleft. They still have some cleft left behind, and then even the mobility of taking the bone graft those days was not easy in children. Trying to raise rib for somebody who is 6 months old. So that is the cause. But for secondary bone grafting, there's a lot of things going for it. One, the anterior bone, the anterior palate will have been formed. So the issue of having hypoplasia is no more there. For those who have constricted anterior alveolar bone, expansion can be done before you carry out your bone graft. And at the age of 8 to 12 years, you have enough cancellous bone to harvest from the iliac area to fill this graft. So there is a lot going for alveolar bone graft, secondary bone graft, as compared to primary bone graft. If you have been practicing secondary bone graft in your center, following through with your X-ray, you will see the result is very good. But it also has its own problem. But those problems are being resolved from one point to the other. Initially, when all of us used to take bone graft from the lateral aspect of the iliac bone, some might damage the sciatic nerve, apart from the cutaneous nerve. Now, when you are taking it from the medial aspect of the iliac bone, you are totally away from all those areas. So it is much easier for you. But the problem is that if you don't know how to take bone grafts as a surgeon, call your colleague orthopedic surgeon. But where I was trained, we were trained to be able to do everything together on our own, because very busy, orthopedics is busy. We should all learn it. It will help us for us to be able to complete all the treatment. But if you are managing a cleft patient, your treatment is not complete once you finish with the alveolar bone graft. You must be able to do the lip, do the nose, do the palate at the same time, do alveolar bone graft.
Okay, thank you so much. The next question is a bit heavy, but I think you can just take note of it. You might not answer that. It said, briefly revise the intraoperative procedure. I guess it was when you were having some hitches. So just take note of it. Maybe you can send it later. Now for the next question.
What is the question?
Briefly,
I should review.
Briefly revise the intraoperative procedure. I guess it was when you were having some hitches. They were not able to see you or see the slides. Now, the next question is, what do you do when there is absence of a competent specialist to perform alveolar bone grafts in a comprehensive cleft care team?
What do you do when there is absence
of competent specialists to perform alveolar bone graft in a comprehensive cleft care team?
Well, my advice would be not to do it at all. Because if you don't have the specialist to do it, even though if you are a specialist in oral maxillofacial or plastic or anything, it is good to go for the training. Because we have to train and be trained. Because alveolar bone grafting bleeds a lot, and we don't transfuse our patient. You must be ready to control all those bleeding. But I personally, I don't like transfusing children unless if it is necessary. So you must minimize the blood loss. At the same time, you must be able to raise your own bone graft. If you cannot do that, then you'll be giving your other colleagues who are orthopedics some problem because they might be busy in their own unit. So it is always good to go to a center or send somebody from that comprehensive center to another center where alveolar bone grafting is being done to go and understudy how they are doing it. And then that person should be able to do 2 or 3 before going back to his own center to start doing it. For me personally, anything I'm not properly trained to do, even being specialist, it's better to refer that patient to another colleague that I've been doing a lot of.
Thank you so much. Now, in the absence, hello, in the absence of
Hello,
an, can you hear me now?
I can hear you, sir.
In the absence of an orthodontist, how do you ensure that you have an adequate space to carry out a good bone graft?
Well, what I said before was that, well, we are also trained as a dentist. We have some training in orthodontics. So the minor area, like using removable orthodontic appliance to cause a expansion, is very easy. But that one, the patient can even be doing the activation of the palatal expander at home themselves. So we have some couple of patients like that we have to construct a removable orthodontic appliance for them. We show them how to expand it, to activate it every 2 weeks, which they do. But if it's a complex orthodontic treatment, then the best thing is to send the, as I said earlier, I can send patient to Kano. Since the orthodontic treatment there is free now, we have an orthodontist on ground. You send the patient to the center. You don't just force yourself that you must do everything, but we must follow the procedure. If you follow the system, then the patient will be very happy with us, rather than us carrying out something that we cannot finish. But all the minor cases that we had, it was easy for us to do the palatal expansion before we carry out our available.
Okay, just 2 more questions, and then we can sign off. Now, with peri-apical radiographs alone suffice to assess the walls after the repair?
It's not suffice alone, but the issue is that if that is the only thing you have, then you use it. Like in my center, we have a orthopantomogram machine, so we're able to take OPG all the time. If you have a occlusal X-ray will be better, but you find out sometimes it's not even available in our own country. So you have to do with what you have. Use what you have.
Okay, thank you so much. So, and another question: have you carried out any bone graft on adult patients, and how do you compare the success with the adults and those of children?
Well, I've carried out bone grafts in adults, not for Aviola bone graft, for mandibulectomy and other surgery that we do. It's as good as depending on how you do it. Because there are patients that have total mandibulectomy, you do bone graft for them, it heals. So it's the same procedures. But the issue is that you use different bone in each of them. In Aviola bone graft, I do mostly for children. I've not done an adult case. But bone grafting in adults also, it depends on the medical problem of the patient, the age of the patient, and the soft tissue, where you're using it. Are you using it for malignant lesion? Are you using it for benign lesions? Depending. I think that will be another topic for another day.
Okay, thank you so much. And then one last question, and then we can close up. Now, do you consider oral nasal fistula a statutory clinical presentation of alveolar clefts?
Sorry, sir, I didn't get the question very well.
Do you consider oral nasal fistula a statutory clinical presentation of alveolar clefts?
No, it's not in all patients. Somebody who had a partial cleft, some of them also have a alveolar bone graft. It might be a small graft. It doesn't mean they are going to have oral nasal fistula. But for those who have, especially those who have cleft lip, cleft palate, and cleft alveolars, it's likely, especially with bilateral cleft lip, in that area, you are likely to have a fistula. But that's why I said it is an opportunity for you to close the fistula directly during your alveolar bone graft. Since you are raising palatal flap, just trim the dead end of the fistula and then close directly. So it is not mandatory that every patient with alveolar cleft is going to have oral nasal fistula, but majority of them do.
Okay. Thank you so much for the wonderful presentation, and I must congratulate you on behalf of West African College of Surgeons and the SMILE trend for the wonderful presentation. Thank you so much. And
thank you, sir.
So the participants, I must say, thank you for attending this program. To Nkiru Kobi and Esther, I must say thank you for attending. The Smile Train program continues on Monday. Have a nice day. It's me, Professor Ekenze from Enugu.